Ladies and gentlemen, welcome back to Chapter 4 of Nephrology. We're going to be talking about sodium disorders, specifically hyponatremia and hypernatremia. That's right. Hypernatremia, what are some causes? Well, number one, a free water deficit. If your patient's not getting enough free water, they're going to have a large deficit that's going to be unmasking your hypernatremia. Number two, they're going to have dehydration that was treated originally with normal saline replacement at first. We've all seen this. We've all seen, oh, patient comes in, they have diarrhea, they have vomiting, give them fluids. The next morning we come back, sodium's through the roof. We did it. Ooh, that was us. Yes, that was us. And lastly, some other causes. The other main cause that you have to keep in mind is diabetes insipidus. Diabetes insipidus can be caused by a lot of forms. Number one, diabetes insipidus can be caused by a failure to produce anti-diuretic hormone. That's called central DI, because our brains that are supposed to produce the anti-diuretic hormone is not producing it. Therefore, it's a central problem. It's a problem with administration. It's a problem with the central core of the body. I'm not producing enough anti-diuretic hormone, or I'm not producing any anti-diuretic hormone. Therefore, my body just does not see it. The other form of it is nephrogenic diabetes insipidus. In this form, the receptors are insensitive. They're not being polite. They're not insensitive, and that means that anti-diuretic hormone's swimming around, but the receptors can't fit that lock and key. They're not going together. They don't like each other. They don't get along. It's like a 3-year-old child, these receptors. They close their eyes and they pretend like nobody's there. Nope, nope, nope. I didn't do anything wrong. I'm not going to admit to it. And this receptor does not play ball with the anti-diuretic hormone, and therefore you don't get the effect that you need from ADH or vasopressin. Some other causes of nephrogenic DI are hypokalemia. Yes, patients with hypokalemia can have nephrogenic DI. Hypercalcemia can also have nephrogenic DI. And 2 drugs that right now, as you're going through the book, I want you to write down, because these 2 drugs are board's favorites. The first is lithium. Yes, lithium gives you nephrogenic DI. And second is demeclocycline. Oh, right, everyone remembers lithium, but they forget the defunct antibiotic demeclocycline. Demeclocycline is an antibiotic that is actually used for the treatment of SIDH, which is the opposite disorder of diabetes insipidus. But people forget it causes DI. So lithium toxicity, diabetes insipidus, diabetes insipidus, and good old-fashioned demeclocycline. Remember that. And remember, hypokalemia and hypercalcemia, all 4 will give you insensitive kidneys. They don't want to work with you. They don't want to play ball with you. They're just terrible. Nephrogenic DI. Now, hypernatremia leads to neurologic abnormalities. You have to remember, it's not just hyponatremia that makes you all confused and loopy. It's also hypernatremia. It will give you confusion. It will give you disorientation. It will give you seizures, and it will give you coma. Sounds kind of like hyponatremia. Why memorize it then? And most importantly, sodium disorders do not cause arrhythmias. And here's your first basic science correlate from this chapter. Sodium disorders do not cause arrhythmias. Why? Because the membranes of your cardiac muscle and my cardiac muscle and the guy sitting next to you's cardiac muscle and you're attending down the hall's cardiac muscle and the hot nurse over there, all of us use calcium to depolarize our cardiac muscle. Now, both central and nephrogenic diabetes insipidus are going to give you low urine osms. That's right, you're going to have low urine osmolality, low urine sodium, an increased urine volume because you're not anti-diuresing, you're just diuresing. And lastly, no change in urine osms with water deprivation. Holding back on water for them is not going to change anything. It may even make it worse. Now, I am telling you, ladies and gentlemen, that central and nephrogenic diabetes have the same urine osm, the same urine sodium, low and low, and an increased urine volume. So how do they differ? Let's talk about it. Here's how they differ. Central and nephrogenic DI differ in the following methods. It differs on what happens when I give you DDAVP. In central diabetes insipidus, the main problem is you don't have enough anti-diuretic hormone. Therefore, when I go ahead and give you anti-diuretic hormone as DDAVP, whether it's intranasal, IV, however you want it, you're going to have a decrease in the urine volume. This is because your receptors are seeing ADH for the first time, and so they begin to anti-diurese. Oh, so urine volume goes down. The next thing that happens is your urine osms go up. Urine osms go up because, again, those receptors are coming to life. It's like Voltron. They've come together to form a great robot. Yes, that's basically what's happened here. Your anti-diuretic hormone is now joining to the receptors of your kidney, and now they're anti-diuresing. So you're going to see an increase in urine osms, again with DDAVP, which is known as vasopressin, which is also known as ADH. And lastly, treatment. Treatment is DDAVP or vasopressin. Why? Because it fixed the urine volume problem, it fixed the urine osm problem, and therefore we know we're treating the underlying problem here, which is a lack of ADH. How does that differ from nephrogenic diabetes insipidus? Well, I told you earlier, nephrogenic's like a little kid. It doesn't want to play ball. It's not going to want to hang out. It's going to close his eyes and pretend like nobody's in the room. And that's what ends up happening here with nephrogenic diabetes insipidus. When I give you DDAVP, you're going to have no change in the urine volume. When I go ahead and give you DDAVP, I'm not going to have any change in the urine osms. So how do you treat someone with nephrogenic diabetes insipidus? Because we know that through giving DDAVP, I can distinguish the two. Very straightforward. Correct the underlying cause. That's right. If they have low potassium, give them potassium. If they have high calcium, give them a thiazide or a diuretic and other causes. That's right, that's it. That's everything for hypernatremia that you need to know for USMLE Step 3. That is the most high yield information. That's what they're going to ask you, and that's what you need to know. Now let's move on to hyponatremia. Now in hyponatremia, you've got neurologic abnormalities. Can you name the 4? That's right! The same ones: confusion, disorientation, seizures, and coma. Almost the same thing. So what do you do for these patients? Well, the first step in any patient that has hyponatremia, you must determine and assess what their volume status is. Once you know what kind of volume status they have, then you can determine the cause. Now, there are 3 volume statuses, or stati. Is it stati? I think it's just statuses. Well, whatever it is, you have 3 volume states when it comes to hyponatremia. You've got right down the middle, the Goldilocks euvolemic hyponatremia. Then, on the far end, on the lower end, you've got the little engine that couldn't. The little engine that couldn't, that's hypovolemic hyponatremia. They're dehydrated and they have low sodium. And then, on the other side, you've got hypervolemic hyponatremia. Each one has a different cause and therefore has a different set of rules and regulations and guidelines of what we do for these patients. So let's go to hypervolemic hyponatremia. I love saying this on rounds. Well, this patient has hypervolemic hyponatremia. What are we going to do? Well, the first thing we're going to do is we're going to find out why. They could have congestive heart failure, they could have nephrotic syndrome, they could have cirrhosis, or they could even have some other issue. But have you noticed right here, every single one of these is a state in which they're volume overloaded. In cirrhosis, they're not producing enough albumin, oncotic pressure is low, they're volume overloaded. In nephrotic syndrome, they have greater than 3.5 grams of loss of protein per day, therefore their albumin starts to drop and they have edema, they're volume overloaded. And again, with congestive heart failure, you have the exact same issue. They are volume overloaded and hydrostatic pressure is off and oncotic pressure is off and they have edema. They're hypervolemic. There's too much fluid. And so all this fluid around dilutes out the sodium. And so they're too much volume, sodium dilutes out. And so they're hyponatremic. How do you manage these patients? Treat the underlying cause. That's right. You've got 3 syndromes right here that are causing this syndrome. And so you can manage them by correcting the underlying cause. Get their cirrhosis under control. Well, there isn't much you can do there. Try to give them the correct medications and so forth that you learned in hepatology chapter. In nephrotic syndrome, again, try to treat the underlying nephrotic syndrome it is. Could be steroids, could be cyclophosphamide, could be nothing. Or treat the congestive heart failure. Make sure that you use the 3 medications that keep their heart working. Beta blockers, ACE inhibitors, or ARBs, and spironolactone. Get that thing going! And that's how you treat hypervolemic hyponatremia. What about the others, far end of the spectrum? Hypovolemic hyponatremia. He's just so hypo. He's tiny. He doesn't have enough sodium. Well, what are some causes here? Number 1, diuretics will do it too. Diuretics will leach your body of fluid and sodium as well. GI loss of fluids is one of the most common that you're going to see. This is vomiting and diarrhea and vomiting. Or it could be both at the same time. Yes, ladies and gentlemen, if you've ever experienced a wicked flu-related symptom or potentially a bad food-related symptom and you've had both vomiting and diarrhea at the same time, you were probably hypovolemic at that time. Another is skin loss of fluids. Yes, patients who come after burns or from heavy-duty running and they are a marathon runner. Oh, marathon runner, that's right. Marathon runners get hypovolemic hyponatremia. In the history, look out for diuretics, Lasix, thiazide diuretics. In the cause, stop those diuretics. Look for GI loss. Maybe they were afflicted by, let's say, for example, a peanut butter and jelly sandwich they ate while they were on rounds. And then what ended up happening is 2 hours later, they vomited all over the pulmonary chairman's shoes. I wonder who that happened to. Might have been me, I'm not quite sure. And last one, it could be a person who had a marathon that they just ran. It could be a fireman caught in a blaze from burns or from sweating. These are causes of hypovolemic hyponatremia. So now, hypovolemic hyponatremia, what's going on? Well, first what happens is you lose water and a little bit of salt. But the problem is the patient is only replacing the water, only drinking water. They didn't see their Gatorade commercial. So they lose water and a little salt, and they replace it with free water. Over time, sodium levels steadily drop. And that's what happens with hypovolemic hyponatremia. The patient's not replacing the sodium as they're losing it. Now the last form is a euvolemic, or a normal volume status hyponatremia. The most common cause of this is SIDH. That's right, we love SIDH. It's one of those backward type models where you have to think inversely, right? SIDH. Now what are some causes of SIDH? Well, we're going to go through those. But what's another form of euvolemic hyponatremia? Well, hypothyroidism causes a big problem. Another psychogenic polydipsia, hyperglycemia, and lastly, let's talk about hyperglycemia. Now, in hyperglycemia, your sodium is going to drop 1.6 points for each 100 milligrams above the normal value of glucose you have. That's right, the sodium will go down every 1.6 points above 100. So if you have patients that are going to present to you with DKA, the glucoses are going to be in the 800s, their sodiums are going to be very, very low. Remember, these are caused by the hyperglycemic effect. You have to correct for them based on this equation. Now, how do you treat patients who have a euvolemic status but they have hyponatremia? Just like with all the rest, correct the underlying cause. Replace them with normal isotonic saline. The sodium levels will come back up, and check the serum sodium frequently. Now let's talk about Addison's disease. Addison's disease is an insufficient aldosterone. And what does aldosterone do? Aldosterone holds on to sodium and kicks out potassium, and hydrogen follows. So we hold on to sodium. 3 water molecules come along with it. Well, what ends up happening is if I'm not producing enough aldosterone, I'm going to have a low sodium with hyperkalemia and mild metabolic acidosis. Remember, I told you when aldosterone kicks in, sodium levels go up because you hold on to sodium and you're spitting out potassium and hydrogen. So the inverse is going to happen if you don't have enough aldosterone. You're going to lose sodium in your urine, you're going to be hyponatremic, and you're going to be hyperkalemic and have metabolic acidosis because you have too many potassium and hydrogen ions just floating around that were supposed to be peed out. How do you treat them? Give them aldosterone replacement such as fludrocortisone. Now, SIDH, I told you earlier we're going to talk about the different causes of SIDH. SIDH can be caused by a CNS abnormality, such as a tumor. It can be caused by lung diseases. It can even be caused by certain medications, such as sulfonylureas, or the one that's so popularly implicated, SSRIs. Yes, every time you get a consult from the floors and there's a psych patient and they say the sodium level's off, the first thing the doctors are going to say could be the SSRI. But remember, keep a broad view. It could be something else. But yes, SSRIs have been implicated with SIDH. Another common cause is pain and cancer and sepsis. The most common cause being sepsis. Now, SIDH is associated with the high urine sodium. Why? Because I am not diuresing, and so I have to get rid of the sodium. And therefore, when you have too much antidiuretic hormone, I'm not losing water, and so I have to give up the sodium. Sodium is lost, and you have values greater than 20. You're also going to have a high urine osmolality, greater than 100, and a low serum osmolality, less than 290, and a low serum uric acid. Now let's talk about these. Why is the serum uric acid so low? Well, the uric acid values are low in SIDH simply because of the fact that the volume status is higher than normal. You have a lot of volume around, and so you just dilute out your uric acid. Lastly, you're going to have a normal BUN and creatinine and a normal bicarb level. So SIDH is associated with high urine sodiums, high urine osms, low serum osms, low serum uric acids, and a normal BUN, creatinine, and bicarbonate. Again, I want to point this little point out right over here. Hyperglycemia caused by an artificial drop in sodium by 1.6 points of sodium for each 100 points of glucose. That's right. Sodium is going to drop by 1.6 for every 100 points of glucose you're high. Now with SIDH, what's the treatment? Well, it depends on the type and the values and what's going on. In mild hyponatremia, there's no real symptoms going on, but the values are off. You're just going to go ahead and restrict the fluids. In moderate to severe hyponatremia, the patients are going to have some symptoms, confusion, possibly even seizures if they're less than 120 or even near 115 with their sodium. For these, you're going to do saline infusion and loop diuretics. For patients who have hypertonic, you're going to give them 3% saline, or you're going to give them ADH blockers such as conivaptan and tolvaptan. Yes, you can give hypertonic saline 2 times. 1, if the values are less than 120, or 2, if they have a seizure, you give them 3% saline and little aliquots. With ADH blockers such as conivaptan and tolvaptan, you're going to go ahead and cause aquaresis. That's right, aquaresis, not just sodium and water, but just aquaresis through the aquaporins. Now, one thing you must remember, you cannot correct the sodium values more than 10 to 12 milliequivalents per liter in the first 24 hours. Now, when I was an intern, I got told this on our step-down unit. Don't correct the sodium more than 10 to 12 milliequivalents in the 1 liter in the first 24 hours. I was like, okay, what does that mean to me? Well, that basically means 0.5 to 1 milliequivalent per hour. So if you're checking it every 4, which is usually what we used to do, you can get an idea of what to do. Lastly, if you do it too quickly, if you correct too quickly, what is the syndrome we worry about? Is central pontine myelinolysis. Central pontine myelinolysis, the locked-in syndrome where they can only blink. When they have chronic SIADH, this is because their collecting ducts are blocked. Chronic SIADH can be treated by demeclocycline, conivaptan, and tolvaptan, causing the aquaresis, which again are the V2 receptor antagonists. And here's one great thing. Conivaptan actually raises sodium as an ADH blocker. Remember this point here. I mentioned it right over here, what conivaptan does. It's a V2 receptor antagonist, which is one of the ADH receptors. Conivaptan raises sodium in that method. Ladies and gentlemen, believe it or not, that is the end of hyponatremia and hypernatremia. That's chapter 4. I'll see you back in chapter 5 when we discuss potassium disorders.